Good morning, everyone. We're going to go ahead and get started. For those of you who don't know Dr. Huizar, he did his fellowship in pulmonary and critical care medicine at the University of Washington, and we were lucky enough to have him join us in our division of pulmonary and critical care in 2009 as an assistant professor, and he's going to be talking to us today about the pathophysiology and manifestations of sarcoidosis.
Thank you.
Yes, sir.
So, as you guys know, we see very little of this disease here in Eastern North Carolina. I am going to try to go through pathophysiology, manifestation, current management, and new therapies that are near us. So, just to refresh some of our memory, is sarcoidosis is a systemic granulomatous disease. Is characterized by activated macrophages in the lungs and affected organs. As you well know, it not only affects the lungs, but it commonly does. It has a Th1 phenotypic response and therefore has a CD4 positive lymphocytes accumulated. Its etiology is truly unknown. There's been many antigens and peptides that have been proposed as trigger agents or related to this disease. Some of them are Propionibacterium acne and granulosum, and some antigens from Mycobacteria tuberculosis like protein cat G and topoisomerase also from Mycobacteria. Other theories have suggested that it's more of an autoimmune disease. Where that has come from is due to the finding that some proteins like vimentin and ATP synthetase have been isolated from these granulomas with mass spectrometry. So also, some people think that this could be, or many of your patients will ask you if this is genetic or hereditary once you tell these patients that they might have this disease. So it's not as rare to see families that have this disease or relatives. So the overall adjusted familial relative risk is 4.7, and studies trying to figure this out have seen that HLA-DRB1, the 1101 allele, was associated with sarcoidosis, and the risk is different if you're African American than if you're Caucasian, being almost double if you're African American. With this, though, you have that HLA-DQB1 0201 is associated with good prognosis in patients of African American, British, and Dutch origin. So a bit suggesting that it's not related to then genetics. It might be more of environmental role that this has. Sarcoidosis, if you think of it, is really a characterized intense inflammation at the site of the disease. It really causes organ dysfunction due to the granulomatous inflammation, not in any other way. Cytokines is also a major factor of this, so you have different cytokines, chemokines, and it's a complex pathogenesis, it's a complex mechanism of inflammation. It has been preserved since fish, where this is more of a process to encase pathogens, parasites, or bacteria. So therefore, is well developed. It's a well-developed mechanism and has certain redundancy to the production of this granulomatous inflammation. So some of the cytokines that have been seen elevated, coming from the macrophages. This is the list, and in an attempt to develop a signature for sarcoidosis, but obviously this is an inflammatory process, so therefore a lot of other inflammatory processes will have similar patterns. The pattern in the bronchoalveolar lavage could be lymphocytic alveolitis. CD4-CD8 ratio over 3.5 is highly suspicious for sarcoidosis in the setting of no other etiology. As I mentioned, some inflammatory markers have been tested or tried to look at. ACE is one of them. It's secreted by monocytes and macrophages. It can also be secreted by pulmonary endothelial cells. This is a little graph from a study showing how other patients with scleroderma or other diseases have lower levels, but certainly you can see patients in the sarcoidosis group right here where you will they have low ACE levels, so therefore it's difficult to just take that as a marker. Lysozyme has been also proposed, but this enzyme will not be expressed by all granulomatous cells, so therefore it's also not as good as a marker. Other proteins like chitotyroidase has been possibly correlated with ACE and IL-2, soluble IL-2, and radiographic stage, but still is not indicative of the disease. Elevated C-reactive protein and ESR, more than anything, will aid you in seeing if these patients have ongoing inflammation and changing on their current state. So that's the best we have right now. So no single marker has been yet found. What's the prevalence is a bit difficult because there's, according to the area where you are at, over here, as you guys know, we see plenty of sarcoid patients. But 1 in 40 cases, 1 to 40 of 100,000. Caucasians is lower rate, third than African Americans. The lifetime risk is about 0.85% lifetime. The predilection for adult is older than 40, so less than 40 is a little more rare. And Scandinavian countries and Japan, believe it or not, have quite a good incidence of them. So obviously that's a predominant Caucasian population. And there is interesting second peak in women at more than 50 years of age. So you suspect sarcoidosis, how you'll go about doing the diagnosis. So obviously you have to find granulomatous inflammation by some sort of biopsy. You have to be sure there's no other etiologic agent, that these granulomas non-caseating, and obviously go through your differential diagnosis. So this will be sort of what you'll find, these granulomatous formations with multinucleated giant cells, epithelioid cells, and then in the periphery some fibroblasts and some lymphocytes. So these will be a big giant multinucleated cells. These little guys over here with a stretched nuclei are called epithelioid cells. Have nothing to do with the skin. It's just the shape that the macrophage takes is the nuclei that transforms. So it's a well-orchestrated reaction where macrophages fuse with each other and try to encase whatever antigen they are trying to encase. That's in the normal etiologic reaction. So obviously in sarcoidosis you don't find an etiologic agent. And the epithelioid cells are surrounding this and concealing these agents, and you'll have that. Let me see, my screen went black here. You'll have that there's a fibrotic encasement of these nodules, and with time they'll form a fibrotic response. So this is some of the agents that we need to look for when we do BAL, where you have to exclude infectious agents. Also, some neoplasm can trick you, especially because of the heterogeneity of the disease. If you have a hypersensitivity pneumonitis, where you might have some antigen that is inhaled, obviously that will be predominantly upper lobe in lesions that you might see. Metals can cause this, so beryllium, aluminum, silicosis obviously can cause this, and other illnesses. So Wegner's granulomatosis, Church-Strauss. So looking at other organs can help you out to distinguish this in terms of kidney or even sinus involvement. Sarcoidosis can also involve the sinuses. Your immune system is everywhere, so wherever is your immune system, you can have granulomas. And it's important to go through this. So if you see there's a diverse differential diagnosis, so taking a good history is key for these patients. And essentially you are more than anything ruling things out rather than ruling sarcoid in. So once you obtain your biopsy, you've excluded these other infections, you culture these patients, you're sure this patient has sarcoidosis. Still, you need to review their history. They haven't forgotten other exposures, travels. Do a good physical exam. Look at their lymphatics, skin, eyes, liver, heart. They might have dysfunction, and the patient has yet not noticed. This obviously has to be, the biopsies have to be stained for cultures and AFP, fungal. Your chest radiograph will help you stage these patients. Is also variable onto their symptoms. Sometimes you'll see a more impressive X-ray than what the symptoms are, but that will guide your treatment. Full pulmonary function test should be done baseline, even if the patient is not complaining. We have a high reserve of lung function, so prior to someone noticing they are short of breath, they'll definitely will have changes in their functions. An electrocardiogram is very important. Conduction abnormalities are frequent. These patients can die from arrhythmias. Ophthalmological exam, the same. They can cause blindness, cataract. So routine eye exam yearly at least. And just usual blood work, liver function, kidney function. Calcium is very important. They might have hypercalcemia, and complete blood count with differential. The urine analysis with 24-hour collection of calcium and creatinine could be helpful if you see a high calcium and you suspect hypercalciuria, as these patients could have nephrocalcinosis. So in follow-up, you need to track the organs that you have recognized as being involved, obviously using the least invasive methods, and monitor for new involvement of common target organs. So how do you stage in terms of the X-ray? This is a stage 1 X-ray, mostly the hilar predominance, hilar adenopathy that you can see here in these patients. That will be a stage 1 without parenchymal involvement. Stage 2, you'll have the hilar lymphadenopathy and parenchymal involvement that you can notice here. Stage 3 is minimal hilar lymphadenopathy with more of parenchymal involvement. and stage 4, which is scarring. Interestingly, these patients can change from stage 3 to a stage 1. Obviously, stage 0 is no involvement. From stage 4, there's usually no reversal. It's very difficult for these fibrotic changes to resolve. In terms of manifestations, so you can get these kind of patients. It's usually more on the Caucasian population, but it certainly happens in African Americans, where they'll present with an acute syndrome. They might have erythema nodosum. They could have a bilateral hilar lymphadenopathy, but they'll have, interestingly, a clinical presentation with fever, polyarthritis. They might have a vesicular or maculopapular rash. They could have acute iritis and conjunctivitis, so red eyes. And frequently, they could present with a Bell's palsy. And chest radiographs could be normal, but as I said, they can have hilar lymphadenopathy. They usually don't have pulmonary infiltrates on those. They can have arrhythmias due to the acute granulomatous involvement of the heart. And it many times have a spontaneous resolution. If your patient were to present like this, it's actually a good prognosis for the guy or the woman, I suppose. It's just matter that these patients somehow have this acute event and it controls itself a bit better. In terms more of a chronic sarcoid patient, that will be most of them, your main organ usually is the lung, so you can be presented with a patient with cough and some shortness of breath. If you send to do a pulmonary function test, you might have just airflow obstruction, so you have to be careful and look for full lung volumes because they will show you a restrictive pattern and a decreased diffusion capacity, which is less common, obviously, of any other disease. So you will not see, like in your asthmatic, that they usually don't have a decreased diffusion capacity, and obviously they do not have a restrictive pattern. So it's important to not only get a spirometry, but a full pulmonary function test. In terms of other things that you can see is hypoxemia, lung nodules, fibrosis, scarring, or infiltrates in the lung. These can also cause pulmonary arterial hypertension. The belief there is that these granulomas are compressing the small venules and arterioles, causing an increase in pressure. You can also listen to stridor or some vocal cord problems because of nerve involvement or airway involvement, narrowing and causing scarring within the airway or affecting the nerves. In terms of skin, you can see plaques, you can see rash, you can see lupus pernio, usually in the face, more of a reddish plaque. In terms of the eye, there's a lot of involvement or manifestation that this can have. uveitis, anterior or posterior, keratoconjunctivitis, and glaucoma and conjunctival follicles. So it's important for your patient to be seen by ophthalmology. In terms of heart manifestation, so interestingly, as I was saying, in autopsy series, they've seen that 40% of sarcoid patients have cardiac involvement, but only 10%, about 10% will actually have symptoms in terms of arrhythmias or conduction abnormalities. It can cause a cardiomyopathy, dilated usually with LV dysfunction. It therefore can manifest in your sarcoid patients as palpitation, syncope, dizziness, or sudden death, as well as with chest pain. In terms of the kidney, you can see hypercalcemia, hypercalciuria, membranous nephropathy, proliferative or presenting glomerulonephritis, and focal segmental glomerulosclerosis. So it's less common, but it can happen. So if you see any of these patients, and in terms of the thyroid, you can have diffuse enlargement, and nodules are rare. on these patients, so those need to be worked out in detail. Sarcoid patients can have an increase or have an increased rate of neoplasias. In terms of liver, you'll see some hepatomegaly, abnormal LFTs. The spleen can be involved, just causing enlargement. In terms of blood, you can have anemia and that comes from bone marrow involvement. So it's important when you see a patient with sarcoidosis and anemia, think about the bone marrow is being involved and therefore causing anemia, and you need to do a bone marrow biopsy. That might be the only manifestation, and obviously you will need to treat this patient. In terms of neurosarcoidosis, the manifestations can be highly diverse. You can have cranial neuropathies, you can have facial palsies, diplopia. It can have a meningeal involvement, so it can appear as an aseptic meningitis. It can also simulate a mass lesion, and it can have hydrocephalus. In terms of parenchymal brain disorders, it can cause endocrinopathies in these patients, and encephalopathies and psychiatric symptoms. So if your patient with sarcoidosis starts having some of these, look for an MRI, and it can also cause seizure, obviously, because of the inflammation within the brain. So you looked through all of this, or I suppose a little before I move on other things of importance. In terms of the kidney and the hypercalciuria and hypercalcemia, remember these patients will have high levels of calcium, so when they are treated with steroids, calcium supplementation is not needed. This will cause hypercalcemia, and then your patient will come in complaining of muscle weakness and pain and constipation because of your calcium supplementation. So it needs to be done with care. Bone densities, if you are highly concerned about their being osteopenic, that's certainly indicated. In terms of endocrinopathies, as I mentioned, is the thyroid, more than anything, is not affected by itself, but due to the meningeal involvement and causing endocrinopathies, it can simulate a full or panhypopituitarism and needs to be treated. So if you're presented with these problems, what are you going to treat? Well, the mainstay of treatment is corticosteroids. If you have a acute deterioration, you can start with corticosteroids. That's the first medication that should be started. High doses, you can come down on these steroids. Loss of function is the main concern here from any organ standpoint. The scarring that will be left on the organ is the concerning aspect. So prednisone and stopping that inflammation is very important. So if you want to use steroid-sparing medications, there's many of them. They've been used with mixed results. As sort of I have alluded a little bit, the mirage of patients that you can get and the symptoms are varied. So you need to see which medication works best for them. Steroids, as I said, is the mainstay though. So Plaquenil has been used with success. Usual doses of Plaquenil will be 200 milligrams twice a day. It can be used as high as a gram. Obviously, with those, you have a higher concern about side effects, and there's plenty of side effects for Plaquenil, from skin rashes, reactions, liver toxicity, ocular toxicity. So if you have someone with high involvement and you're going to start Plaquenil, that might be a bit more concerning if it's due to the drug or if it's due to the sarcoidosis. Methotrexate is considered more of a second-line immune suppressive agent, especially as a steroid sparing. This is used weekly, is used in conjunction with folic acid. Folic acid should be used every day except the day of methotrexate. Starting doses is obviously according to patient size, but doses between 7.5 milligrams a week to 20 milligrams a week have been used. More than that, you can get into some problems with complications. Methotrexate is pretty well tolerated. Most patients might feel tired with the use of methotrexate, so using it on a Friday will be the best approach. And they take it every Friday, and the folic acid every other, all the other days except Friday. The GI, as I was saying, is the most complained of, which might cause some diarrhea, some gastrointestinal upset problems. The other concern will be the side effects, as it can cause some problems in the lung, interstitial lung disease, in terms of fibrosis. Other steroid-sparing agents, Imuran, azathioprine, has been efficacious for pulmonary and extrapulmonary disease. It's also used as a second-line agent. It can be used in conjunction with prednisone, so you can lower your dose of prednisone. These although it's been used fairly frequent in some centers, there is not a lot of information about Imuran, but certainly I have had patients that respond pretty well with these doses. You might get an initial dosing of 200 milligrams a day, and then you can come down on that, although you have to taper it in, so you should not start with the maximum dose. Mycophenolate has been used in these patients mostly for neurosarcoidosis. It seemed to have very good effect for neurosarcoidosis. When used on these patients, you have to be careful with immune suppression and giving them prophylactic antibiotics. It's quite strong. Cyclophosphamide has also been used. Obviously, with cyclophosphamide, the concern is the hemorrhagic cystitis that you can have. It's mostly used for severe cases. It can be started intravenously. The regimen tends to be tapered in with starting 500 milligrams IV every 4 weeks, and it can be increased. The response that you're looking for in these patients should be a decrease on the white blood count cell. Hydration is very important. Starting of cyclophosphamide is recommended to be done in an observed setting, so like an ambulatory unit, and then good hydration. If the patient tolerates this, then it can be turned into oral. But again, reserved to the most severe cases. Infliximab is an agent that has been used, anti-TNF, mostly for neurosarcoid patients, is given every 4 weeks, and it can be then extended. This has not been used as a long-term. The patients have gotten about 6 infusions, 8 infusions of infliximab, and they seem to respond well. My experience, I've seen that these patients tend to taper their symptoms, and somewhere between 6 months after you finish the infusions, 4 to 6 months, you might see recrudescence or a restart of the sarcoid symptoms. So close observation on these patients. And again, you are using this for neurosarcoidosis many times, so you have to be in good communication with your neurologist of what you're doing, what you're giving them, and for them to help you assess their neurological status. Telling you about granuloma formation, as I illustrate here, TNF-alpha is an important mediator, as is secreted by Th1 cells and the macrophage itself. Interferon gamma is also by Th1 cells, and there's other cytokines, IL-12 and 23, that have been observed with this biological phenomenon. P40 is a common component of IL-12 and 23. So it's two cytokines essentially in one. So new therapies down the line are anti-TNF. Is a golimumab, which is used for other diseases right now and is FDA approved for other illnesses. Is a human monoclonal antibody. It has a different isotypes of the G kappa light that binds with very high affinity to TNF alpha. So in that respect, it's different than other agents, and that's the hope that might have more limited effect into this granuloma inflammation. So it forms stable complexes with the soluble and the transmembrane bioactive forms of TNF. Other agent is ustekinumab, that is also an IgG monoclonal antibody. This, as I was mentioning, binds to, or as I was mentioning, P40 is a common subunit for IL-12 and 23. So it binds to that unit. It then, therefore, blocks the binding to IL-12 receptor beta. So this receptor, though, or why it's important, is because it's expressed on the surface of T cells and NK cells and antigen-presenting cells, which are key players in this granulomatous response. So it's been investigated, this agent, and as I recall, it's already approved for psoriasis and Crohn's disease. This essentially will be the proposed mechanism for the blockage of P40, where you block the T cell, you block the feedback and expansion mechanism that the macrophage does once it encounters this granulomatous inflammation. Golimumab, therefore, will bind to TNF, then blocking the effect of TNF-alpha from the T cell and the macrophage signaling to the T cell, then therefore blocking this expansion and persistence of the granulomatous reaction. In addition of the 1223 causing the P40, then these patients have TNF-alpha, IL-1 beta, IL-6, so these will produce IL-12, and therefore that's why IL-12 will be important to block. As I was mentioning, Th1 cells get proliferate with IL-12 and decreasing the interferon and TNF secretion. So I think I mentioned this. IL-23 promotes differentiation and expansion of the Th17 and IL-17A. So this is a different CD4 T cell lineage and has been involved in new mechanism of immunity or understood mechanism of immunity. And this is the mechanism by which sarcoidosis and that fibrous capsule and the scarring that you can see on sarcoid patients is produced. So the hope here is not only that you will block the inflammatory response, but also you will block the scarring. And by blocking this, then you will block the TGF-beta that the macrophages produce. So therefore, not only that, you'll block this, but you will revert your macrophage to a more healthy state. And we have an ongoing trial with these drugs with Sarcoid patients. It's a trial involving several countries. We're one of the sites here in ECU. We are performing this trial, and we'll be closing enrollment in June for this. As far as I can tell, there seems to be a fairly good response to these agents. And with that, I thank you for listening to me, and if you have any questions. Dr.
I'm just curious, is there anything inherently different about those sarcoid patients that have extensive bone marrow involvement?
Not that it has been described.
Anything more likely to have hypercalcemia?
Well, in terms of hypercalcemia, no. The hypercalcemia is thought to be produced by the granulomatous reaction, so it's not related to bone marrow involvement. If you want to determine if your patient will develop hypercalcemia or hypercalciuria, there's new studies showing that checking vitamin D levels, more than anything, not vitamin D25, but vitamin D125, which correlates better with calcium levels, and levels above 75 milligrams in this small study that recently was presented at ATS demonstrated that all patients that had 75 or more had a history of hypercalcemia and hypercalciuria, and all the patients below that didn't. So I suppose it's a way to guide yourself if you see that.
One quick follow-up to that, not all may want to weigh in on this. If you have somebody with vitamin D levels to 125 in that range, and they have underlying renal insufficiency or chronic kidney disease for other reasons, are they more likely to become hypercalcemic since they can't excrete the calcium load as well?
I would guess so.
I mean, if you see that.
In those patients, steroid use actually certainly decreases the calcium levels. Dr. Cook?
Do you see any patients who have both sarcoid and HIV? The reason I mention that is, of course, the pathophysiology of HIV is kind of the opposite of sarcoid. The CD4 to CD8 ratio is reversed, and we frequently are dealing with that issue. So I wondered, not that I would recommend it for therapy, but if HIV is make sarcoid better.
Well, you know, I trained in the era where the heart was available, so I got to see less combination of HIV and sarcoid. I've seen it, and what happened with this is, yes, they have less manifestation of sarcoidosis, and when they get therapy and their immune system reconstitutes, they actually worsen. So it's sort of a bit concerning when you have the HIV getting better and you need to give them steroids or some other therapy to control their sarcoid. So these patients that you have to be careful with. Certainly you have to be sure that the HIV is well treated and that their counts are good enough and that they do not have infection. So it's certainly very important to exclude infection on those guys before thinking they have sarcoidosis. If they had the sarcoidosis before the diagnosis of HIV, yes, they do get better. Yes.
The steroids or biologics that you use, do you
Depends on what the plan of the sarcoidosis is. So if the sarcoidosis plans to stick long, yes, you just treat them. So in the initial presentation, about 50% of the patients will remain with significant symptoms, maybe a bit more. After the first diagnosis, many of them remain asymptomatic. Somehow, the women, there's a prevalence higher in women, and they tend to have a bit more symptoms in my experience. So what I tend to do is start treating them, see if they improve. When they improve and I have no signs that they have problems, I start trying to taper their medications. I obviously try to use a steroid-sparing approach. Therefore, I try to taper first the steroids and leave them on the other medications for a longer time, and maybe I can keep them on Plaquenil alone or methotrexate alone and off the prednisone, or get them as low as 5 milligrams every other day of prednisone.
So I'm asking these biologics, if you stop and you try to start them again,
Oh, you mean the infliximab? I've had patients, yes, that what I've done is, or my approach is, they are poorly responding to therapy, so I start these medications. It's always difficult because of the cost of it. So once they finish their course and if they have improved, I keep them on the same medications they were before. But through the course of the biologic, I try to taper their medication somewhat, especially to a lower toxic dose of the steroids, more on the 10 range. And if I get to that point and the patient is stable, and then I stop the biologic, I keep them on that. I observe them for at least 6 months. If they are doing well, I can taper that and stop it. In these patients with severe disease, many times I have to restart them, so it doesn't go away completely. Yes?
When I was a medical student, which is a long time ago, in Houston, we talked about an association between higher prevalence of sarcoidosis and pine trees. East Texas, eastern North Carolina, Scandinavia, Japan. Is that something that's fallen by the wayside, or is there any further information on that?
No, it's really fallen out of favor. Because if anything, I suppose maybe is not the pine tree or other, is some antigen that is within the areas. So if anything, they have not isolated any of these agents from these granulomatous lesions. What they've with mass spectrometry and proteomics and all this, what they've isolated is autoantigens and mycobacterial products, proteins from the membrane or within the mycobacteria. The other agent, Propionobacterium acne, has been described. Superoxide dismutase has been described. Many models that attempt to model this disease use Zephyrus beads coated with these antigens. So that's trying to study these mechanisms, but not one antigen has been described.
what happened to the blind test? Is this irrelevant for it?
That you know what is that? You know how they make it? Yeah, so it's like skin and some, human material. So yes, no, it's fallen out of favor. It's not that specific. It does help, but not available now. You can see Dr. Kataria might still have some old thing of that.
Yeah. When you use biologics, and do you have a problem with biologics that if you take them off, you can't really reproduce them because of development of antibodies? Do you have a similar problem that if you use biologics and you stop them, you can reproduce the same agent and get good efficacy?
So far, yes. And
Yeah, since you mentioned some of the bacteria and the organisms, they can cause sarcoidosis. When you start them on immunosuppressants, have you seen the monocytes of MAC and others?
no. If you have a bacteria,
If you think
it's
that's a
not.
positive agent of sarcoidosis,
So if there's another etiologic agent, then it's not sarcoidosis, then it's an infection. So you really have to do a bronchoscopy, find biopsies, be sure they are not infected.
but they are not related to the pathophysiology of the disease.
No. So the antigens, what is thought that happens is that these persons get infected, they get an initial infection. Your body destroys these bacteria, so that bacteria are dead. These antigens somehow get encased in the granulomatous reaction and just persist through their life, and therefore that antigen persistence causes that continuous inflammatory response. So,
Same line, you mentioned vitamin D levels.
yes.
So what is the incidence of tuberculosis in this patient population? Because our low vitamin D levels have been correlated very well to pulmonary tuberculosis.
You mean as a risk factor?
So that's kind of, yeah.
Well, the thing is, at every point, we try to exclude infection on these guys. So if you have a patient with sarcoidosis, they usually don't come with.
Incidence is not any more than the common population.
No. And actually, there was a thought quite a few years ago that Dr. Kataria was one of the people that disproved that these patients were somewhat immune suppressed.
Yeah, that's what I was trying to say, because the lower levels of vitamin D levels.
Right. No, actually, they usually have higher.
Since they are higher, so you think they will be kind of protected against tuberculosis. That was study this came 2-3 years ago. Lower levels are correlated to tuberculosis, but if their levels are high, then Dr. Kataria's point is very well.
The problem will be that you would need to grab patients with sarcoidosis, expose them to tuberculosis, and see. So in a prospective study, and it's sort of is difficult because if you get a patient with this hilar lymphadenopathy, right, then you will try to exclude tuberculosis. So it will be then difficult to distinguish if that patient that has sarcoidosis, their gut tuberculosis, as you said, might have killed the bacteria, and then therefore the antigen be an persisting problem, then producing sarcoidosis. So it's difficult to dissect if that were to be the case.
In one of your slides, you clearly show that the incidence of sarcoidosis is higher in the black population.
Yes.
There's also a much higher incidence of vitamin D deficiency in the black population. There's also a significantly higher incidence of prostate cancer in the black population. There have been some suggestions that seem to link vitamin D deficiency to this incidence of prostate cancer. Now, the patients with sarcoidosis would obviously have higher endogenously produced 1.5-5-HTP.
But
I wonder if there is a slightly decreased incidence of prostate cancer in men with sarcoidosis because of the presence of high 1.5-HTP.
no, they actually have higher incidence of cancer. Patients with sarcoidosis have higher incidence of cancer, lymphomas, mostly hematologic, and it's thought to be due to the Well, I suppose that then you'll have to talk to an oncologist why the persistence of inflammation might be promoting cancer, but it will be like rheumatoid arthritis or other inflammatory disorders.
In Crohn's disease, there has been discussion about the interrelationship with the parasitic infestation. And that is, the link is through the effect of Th1, Th2, and Th regulator interaction, and the shift towards the regulatory Th. And that leads to less inflammation in that direction in Crohn's disease. And there is a decreased risk of Crohn's disease in patients in places where parasitic infestations are more common. So they seem to be in the same direction to the extent that some people have suggested using parasites to treat Crohn's disease.
I suppose, but there's a more fancy way to do that. So it's recently a group in Cincinnati used Remicade to treat these patients, and it's severe cases of sarcoidosis. They got a very small group of 6 patients, and it didn't help in few cases. In our experience, we also used Remicade for other diseases like pulmonary alveolar proteinosis. And in our research, we have found that the use of Remicade has off-target effects, and that it causes the increase of markers that are associated with T regulatory cells. So yes, I suppose that might help because you have a predominantly Th1 response on your sarcoid patients. So maybe the use of agents promoting Tregs could decrease that. But the difficulty of sarcoidosis is that it's a very important immune response to the body. So there is many redundancies to the system. So I suppose that if you were to have a way to promote maybe Th2 and therefore balance the other way out, that could be something. But so far, there's no one trying to give parasitic infections. But yeah, it's a thought in the field of having more Tregs. Another important thing, and before my residents go away, is that I just came to my mind is important on these patients with sarcoidosis. They will present with a clinical picture of bronchitic or pneumonic presentation, and many times it's actually a sarcoidosis flare. So it's something to keep on the back of your mind. Is well indicated to start with antibiotics, but if you know you have a patient with sarcoidosis, as soon as you can exclude the infection, you should try to start some immune suppression to control this flare of sarcoidosis. That I suppose will be my only last advice to you guys.
Thank you.
No, I suppose you can.